Bună ziua, dragi colegi! Numele meu este Marian Fanica. Suntem în continuare la Maratonul de Estetică Dentara din Poiana Brașov și l-am alături de noi acum pe doctorul Alejandro Vivas Rojo. Welcome here.
Thank you very much.
It's your first time in Romania?
No, it's my second time.
Oh.
I came here 2 years ago. I'm glad to be here back again, even though in the same place.
You are from Portugal, right?
I live in Portugal since the last 12 years, but I'm originally from Caracas, Venezuela, South America.
Okay, so basically we're neighbors across the ocean.
Across the ocean, yeah. That's fine.
I have a few questions.
Okay.
I know your domain of expertise is implantology, yeah? So you are a surgeon at the base. The first question will be, what are the risks and benefit of placing implant immediately after tooth extraction?
Well, the benefits is that the patients can have the restoration in the same day, but we have to choose perfectly the case to have this kind of technique. Okay, I do it oftenly, but we choose perfect the case to place implant at the same time of doing the tooth extraction, and we can talk days about this, you know, scientific evidence, clinical evidence, but I think that this is the right way to work. Okay, if the patient can have the three-dimensional position of the implants, the patient should have the implant placed at the same day, and the restoration in the same day. Okay, it's our protocol, yes.
And the risk will be maybe if the tooth had an infection, the risk will be maybe if you don't have enough primal stability.
If you don't have primal stability, forget it. It's impossible to place the implant. If you don't have the three-dimensional position of your implant, and if you don't have primal stability, you should not place the implant. Okay, this is the way I think. Okay, sometimes our risk benefits. Sometimes it's worse to place an implant that's going to fail, or place an implant that is not well positioned is 10 times worse. So I guess that we have to follow the protocol first. Three-dimensional information like CBCT, clinical information about the patient, about tooth, which kind of tooth, anterior-aesthetic zone, posterior area. This is not follow rules. Depends of the case, but I think the benefit for the patient and the benefit for us is to place the implant and place the restoration, immediate restoration in the same days.
So it's not for every single case?
No.
You have to choose it wisely, otherwise it will fail and
we have to study the case, okay? First of all, you have to study.
You have to do your homework first.
Yes, we have to do, first of all, the three-dimensional information about the patient. It's like an example. We cannot place implants we don't have CBCT scan, okay? It's like an example. Then we have to see all over the case. It's not a question that do you this technique? Depends the case, the patients. It's very broad that, you know.
My next question will be, because last night we talked a little bit about guided implant placement. Are you using guided implant placement in your daily life? It's sometimes or all the time it's a must for every case?
It's not a must. It's
not a must?
No, for sure not. I think that this, I always say to my students, guide surgery is a GPS, but they don't teach you how to drive. Okay, guide surgery, it's fantastic. It's have a lot of benefits to the patients. It's got a lot of benefits, but I don't see that it's an way to do in all the cases. It's like an example. If you do a graft, how you can do it?
Yeah. You have to open the flap. You still have to do it the traditional way.
Open. It's like an example. I think that the future is digital. I think the future is digital information that we're going to do in our cases. But I think that to tell that 100% of my cases should be done by guide surgery, answer is no, for sure no.
That will be also your recommendation for new implantologists, because you have a lot of experience in placing implants. Maybe in your practice, sometimes free-handed, it's much faster than using a guided place implant.
Okay, I'm going to answer in another way. How you can be implantology or surgeon without open a flap? Okay, you should know first the basic principles of surgery. Implant surgery, it's a basic implant, or not the basic, sometimes advanced surgery skills. So I don't think that if you tell me guide surgery and newest implantology or younger implantologists will focus on the guide surgery, I think it's a wrong way. You know, you have to sometimes open a flap to see okay? And
maybe you are an implantologist scared of blood, you know, and then then you don't want to open a flap, so you'll go transmucosal.
Okay.
Yeah.
Next question, because this is a philosophy.
Yeah,
you know?
I know.
I think that the 80% of the success in implantology is flaps, okay? It's information and it's suture. If you don't know how to open a flap and we don't know how to close it, I think this is the two ways, this the beginning and at the end, the most important thing, okay? So guide surgery, if you have attached gingiva, if you have a huge bone, yes, for sure. 80% of my cases, I have to do graft.
Yeah.
80% of my cases, sometimes it's good I will say that it's good for information, okay? 20% of my cases, for sure, we can do guide surgery, but you have to choose the case for that. Yeah. So it's impossible to tell me that 100% of your cases, no way, no way, or I'm not agree, okay? People says, I respect, okay? I respect all the positions. With scientific evidence, I respect it. But in my experience, answer is no. Okay. And I use it, guide surgery, for sure, yes. Yes, but not all the cases.
I see. The next question will be related to the first one. It's worth the risk of placing an implant in an infected area?
Scientific evidence says yes and no, both of it. Depends. Depends which kind of infection, and depends what you are achieving too. Okay. If I have a destroyed zone, I have to graft it. I'm going to put it another way. For me, implant is to place in 360 degrees of bone. If I don't have bone, I cannot place an implant. I can place an implant and recover the bone and to do graft, that's okay. Okay. If I see huge infection or if destroyed tissue, answer is no. Okay. So sometimes it's better wait to graft, to recover the bone, to recover the soft tissue, to recover all the conditions to the patient to place the implant. Yeah. Think over something. Sometimes 4 months or 6 months, you're dependent the whole life on this treatment. So sometimes you say to the patient, why to do it fast? Philosophy sometimes is do it slowly and be more sure. Okay, if I have to place an implant in an infected zone, I can do it. Yes, you can do it. Yes, but sometimes depends on the infection, depends on the grade of the destruction of the tissue. Okay.
So the better way will be here, the patient will pay off in the end. So sometimes you have to postpone the placement of an implant just to be sure that everything is fine there.
My philosophy is to recover first of all the bone.
Yeah.
If you have the bone and soft tissue, you can place an implant. Sometimes you can do it at the same time, and so sometimes you can't do it. So this is not a road of fast, or how many implants you place, or how fast are you placing the implants. This is not the question.
Yeah.
The question is how to restore that implant to long-term treatment. So sometimes 3-4 months is not enough. Okay, so
you have to wait more.
Yeah.
The next question will be about a controversial topic about immediate implant loading, and also the difference between the immediate implant loading and immediate provisualization.
Temporization.
Temporization, yeah. In how many cases you'll go directly to immediate loading? You need a high...
Full arch? Yes,
yeah,
for sure. For sure. I will try to. If I have good primary stability, if I choose the right case, if I have three-dimensional position, I will go forward for sure for do an immediate load.
But if you have a single tooth, for example...
Depends. In my protocol now, in what we're doing, immediate temporalization, we are doing. Just for two reasons. First of all, we are going to have all the soft tissue achievement. And second of all, we have the temporalization of the patient. Okay, yes. If we have the conditions, yes, it's an OB. Patient should leave with the immediate restoration. Yes, it is. Okay, in our protocol, we were last night talking about CAD/CAM, Instagram, whatever. We try to do it.
Yeah, you can do it fast now, and you can do it better, which is even better if you can do it better.
For the patients, for you, for everything. Yes, it is.
And my last question will be about the partial extraction and socket preservation. I know you are not a big fan of partial extraction. Tell us, not why, because maybe it will take half a day, but tell what you'll do. Yeah, or 3 days.
I have good experience. I have good friends that they are very fan of this technique. Now they begin to have the first scientific evidence in these last 2 years about what is PET. Okay, I see cases, and I maybe can agree a lot of things. I have good friends like Howie Gluckman, Darcy from Portugal. They are really fans of this technique. I cannot tell something that I'm not familiarized. No. Okay, I have 0 cases in my life of PET. I can solve it with other kind of techniques. I respect all the techniques. Okay, all the techniques I respect. Okay. I respect, but you don't have time in your life to learn all the techniques.
That's true.
Okay, and you cannot be all your life trying to find the alchemy of everything. I respect it. Now they begin to have scientific evidence that is truth. Now they begin to have something not controversial, because it's not controversial. Maybe in 10 years they are right. Yeah. But like Alejandro Vivas, I have no experience with PET. I follow a lot of friends of mine, as I told you. I believe that maybe it's working, but I cannot tell you because I'm not familiarized with the technique. I am not the right person to talk about PET. Other person here will talk you. It's fine. But
and about the socket preservation?
It's an hobby. Yeah. Okay, how you can. It's what I always think. Socket preservation is 80% of our success to not to lose bone. Socket preservation is socket reconstruction. Yeah. Okay, in my lecture today, I will talk about that. I think that we cannot take out a tooth without thinking in socket preservation. Okay, we have to preserve the socket or to reconstruct the socket, to place an implant in this, and it's in the same time or in the second time. Yeah.
So do as little damage as possible?
Yes, for sure. And the patients, we have to think about the aesthetic outcome and the functional outcome. If you take out the teeth, you know that 35%, 40% of your bone is going to be loose. Yeah. So with which technique, with what we're going to graft, this is another question. Yeah. Okay? But for sure, socket preservation or socket reconstruction is an hobby in our daily work. In our daily work, yes, it is.
So your recommendation will be always go with what you are familiar, with what you feel comfortable in general. For example, you said you are not feeling comfortable with partial extraction. You're not going to do that. You are feel comfortable with different techniques.
I read it and I see cases. Okay, that's fine, but I can solve it in other ways. Yeah. So I respect, and in 5 years maybe we can talk.
Yeah. When we have more scientific data, and
yes, it is.
It will be black or white, because now it's grayish, some kind.
Now it's gray. Yeah. You can say white and you can say in black. I'm not telling it's white. I'm not telling it's black. I'm telling it's gray. Okay. Maybe they are trending forward. Maybe in 5 years we talk, and if they have a huge scientific evidence, we talk about it.
We'll have another interview in 5 years for sure. Yeah, thank you for being with us here today. It was a pleasure. Looking forward for your presentation. I know for sure that will be a lot of interesting things to talk about. Sure. We'll see in the audience.
Okay.
Yeah? Okay.
Thank you very much.
Thank you. Have a good day.